I think, all now recognize the importance of the opioid problem, and certainly in our earlier polling, it even seemed that it was a very high rate of people doing the right thing. However, when you actually look at data that's been published in recent years, not everybody is plugged in, so I do think it's worth going through again. Mm-hmm. This was 2 days ago for my Buffalo newspaper. The opioid crisis may be over, according to a county administrator, but the experts disagree. You do a laparoscopic appendectomy for acute appendicitis. 5 hours later, you're ready to discharge. What do you send them home on? All right, I'm going to move on.
Is
that too soon?
Because we did it the first part. So
I know. We practiced, right? This question's irrelevant.
So okay. Are you really 100% with that?
Our group is, because we had an intervention. We really did.
With someone who wasn't...
No. We just, as a group, got together and decided we were going to do this. And
the question is, then they're going to come back and you can't call in the narcotics. So what do you do?
Say that again?
The question has been in previous years when we talk about opioids, that if you risk the chance of sending them home with nothing, you're going to get the call in about 4 hours or 3 a.m. that you have to write them a script.
And you can't do that, right? Is that what you're saying?
Saying
it's harder to do that now,
it's a pain
right?
to do that.
Right, it's harder.
They have to come back to the hospital.
You say come back to the ED, I guess, but we have not had that problem for acute appendicitis. The same question about umbilical.
So do you put them on schedule?
Yes, every 4 hours, alternating.
That's
When they're awake, alternating acetaminophen and ibuprofen.
So Julie Rios is going to be giving a talk here, and actually I was looking for your title to introduce you, but I'll do it later. But she's one of our gynecologists here at Cincinnati Children's. You take care of adult patients.
Correct.
What about what's happening in adults? Are you giving less narcotics to the adults?
I give less narcotics to the adults. So I also try to use acetaminophen and ibuprofen, and then I will send them home with a few of the narcotics separate. So it's not linked to the ibuprofen kind of as breakthrough. So if you get that call in the middle of the night, they have something that they can use as breakthrough, but it's only for 1 or 2 days.
So you give a few.
I give a few, and it's just the oxycodone by itself.
So let's people chat in the group. I'm very curious what people are doing in other countries with narcotics. Okay, let's keep going.
Can I ask a question? How many people are using Toradol in these kids? Like give them a dose of Toradol before they wake them up?
I always do.
I'm a big fan of Toradol.
I have some data on that too a little bit later. So
Sorry.
No.
Thunder Stealer.
Looks like for umbilical hernia repairs, it's either just acetaminophen or the combo. But the background here is over the past 18 years, 9,000 children and adolescents have died from this. Mortality rate has increased threefold, mostly males. But even in kids 0 to 4, there's a 7% death rate from kids getting opioids, and 25% of those have been homicides. 81% are adolescents. The heroin death rate has increased 485%, and opioids almost twofold. This is a 2018 publication.
Mac, Kurt Heiss just wrote. Kurt Heiss, for those of you who don't know, from Atlanta, has talked to us before in this event about enhanced recovery. He says the RTS, what's RTS?
Return to system.
The return to system. That's a total Atlanta term, because I don't think the return to system or coming back to the hospital or callbacks are the same for those with or without opioids if the Tylenol and Motrin doses are scheduled and given in advance. Kurt, thanks for that.
Thank you, Kurt. So here's some data again, not just audience. So here's a study looking at 06 to 14. Again, maybe we've gotten past that now, but 68% of those patients were prescribed opioids. And the adult general surgeons tended to give more than the pediatric surgeons. And the opioid group has increased ED visits for constipation. And I know I've seen that. So some data for our umbilical hernia rethinking back to our own results. I'm sorry that's small. This is 12 to 15 data. 4,000 umbilical hernias, 52% received post-op opioids as opposed to our data, which was zero. In our vote right here, right?
Oh, here.
Yeah. Here, in the vote.
Yeah.
6 years old or older tended to get more opioids than younger kids, and southern U.S. was more problematic than Northeast. And again, the durations less than 3 days was 50%, 4 to 10 days was almost 50%, and greater than 10 days, 4%. So again, recent years have shown this to still be a real problem. This was a small study led by David Rothstein and Sarah Cairo at our place in Buffalo, just published earlier this year, where this is the intervention, Todd. So we looked at how much pain medicine we gave for simple things like appendectomy, and then we did an intervention where we educated everybody, including nurses, anesthesiologists, the whole hospital.
Yep.
And then we remeasured again after the intervention. This is more of a you can do it slide. So here is the first post-op orders, use of APAP as acetaminophen again, ibuprofen, ketorolac, morphine, and then a combination of hydrochloro and acetaminophen. And the blue is after the intervention. You can see that dramatic increases in non-opioids or narcotics. It was interesting that morphine didn't change.
Yeah, I saw that. Is that recorded because it was given in the operating room? That was given by anesthesia, probably.
No, this is post-op surgeon ordering.
Okay.
So you can imagine maybe an early post-op 1 dose or something like that. Then this just sort of restates those same information and shows p-values to what was significant in their change. And this is now at discharge, pre-intervention and post-intervention. So pre-intervention, 84% of our patients got narcotic at discharge for an appendectomy, down to 7%. 31% got acetaminophen, up to 94%. 58 got ibuprofen, went up to 86%. Miralax automatically at discharge dropped from 77 to 47 as we had less problems with constipation.
It's amazing. So Kurt uses gabapentin too. Do you guys use that at all?
I don't, but anybody in the room could
Does anyone
comment on
here use
that?
GABA?
I'm interested.
Dan?
I don't personally use it, but
So
Mark can use
Von
Mark should be
Allman
able to.
from Cincinnati, let's pass it around. Von Allman from Cincinnati says that we use GABA here. This is Mark Wolkan
No, we use GABA extensively
in Atlanta.
In Atlanta, Kurt got us started on that, but it's really remarkable how it's changed the pain management for the kids, and even for the kids that have had major operations. When you give a dose preoperatively and continue it post-op, it's really remarkable how well they do.
Can you tell us how it's dosed?
So we're using basically 300 milligrams TID in the bigger kids, and then I'm not going to say our dose publicly. It's in the order set, so I don't know what it is for the smaller kids. Kurt can text it in or type it in.
So Dr. Hayes responded for the gabapentin dose in the younger kids, 5 milligrams per kilo per dose, TID for 3 to 5 days.
What about in kids who are NPO? You continue to give it to them even if they're NPO?
Well, as part of our ERAS protocol, we have very short NPO times. They're NPO if they want to be. I mean, one of the challenges with GABA, though, in some of the younger kids, it's a large volume in the liquid form to get the right dose in, but it hasn't been a terrible problem.
Has it helped in operations like pectus repair? And have you seen a decrease?
So I think, but we're doing multiple things in the pectus patients. We're also doing intercostal nerve blocks and some things like that. We just now I think we finally got our cryoprobe. I don't think we've used it yet. We're going to do some of that as well. But for example, in my bariatric patients, it used to be the first night they were usually kind of miserable, and we went from post-op day 1 discharge about 20% of the time till now 50+% of the time we can get them home on the first post-op day.
Fred Rescorla.
Yeah, we use gabapentin as well. It's mainly with our pectus ERAS protocol,
Okay.
and found it to be helpful. But there are multiple other aspects of the protocol.
Just out of curiosity, are you using that in adults, Julie?
Decrease.
Did you change the way you manage patients post-operatively or not formally yet?
I don't know if we formally did.
Okay.
I mean, most of mine is laparoscopic surgery, and so most patients go home the same day. Foley's out before we leave the OR, so trying to make sure the patients are doing well. From a open standpoint, if I do an open case, I've used a lot of tap blocks with anesthesia, and most of my patients go home post-op day 1.
Tap blocks. Who here is using? Can you explain what a tap block is?
So essentially, it's a medicine that goes in intrathecally into the, they essentially give numbing medicine, and it's a catheter that stays in that essentially numbs the abdominal wall and essentially allows them to get up, move. They'll pass gas that same day because they're not really using any narcotic medication. And we just schedule ibuprofen and Tylenol with it.
And we have a question from Dr. Gray, Fabian Gray. Anyone using IV Tylenol, and are you having trouble with your hospitals letting you use it?
Occasionally, and yes.
I use it. We use it quite a bit, at least in Akron and Cincinnati. I don't know here too. I'm getting the nods about here too. Yes.
I was going to make.
Come here.
I want to make a. So
You're really
IV,
pretty.
IV Tylenol is very expensive, as everybody knows, and I know I'm involved with. I guess I'm one of the IV Tylenol police in our hospital, along with our P&T committee. But we have where we've loosened up is in places where it's appropriate, in our cardiac ICU and the NICU and some places like that. But the reality is that it's no more or less efficacious than per rectum Tylenol. So unless if your patient has a rectum, and it can be administered that way, I mean, it's literally cents versus it's a lot of money. But the other piece, the other confounding factor is that we've actually softened up on it a little bit because it is now much cheaper than it was. It used to be hundreds of dollars a dose, and I think it's maybe $20 or $30 a dose. But the reality is that it's per rectum works just as well with the same
And that's
bioavailability.
prospective randomized trials.
I don't know. I don't know. Mac's calling me out on whether it's Class A evidence. I think
news.
it's
You're giving us fake news.
fake news. Well, I know there's some pharmacokinetic stuff that the pharmacists show me in the pharmacy
some
literature
patient
about
data in there.
bioavailability.